So we have gone through home-based care and also communication. This psychosocial support is also an integral part in which we will get an idea about what all we can do to our patients. So it will be taken by Ms. Reshma. So I just want to introduce her. She has completed her BSc Nursing, Master of Social Work, and has done various certification in foundation course in palliative care and nursing. She's been with us for the last 6 years and has worked in the psychosocial rehabilitation of patients and is currently focusing upon creation of model palliative panchayat and community mobilization. She's a section head of social engagement department in Pallium, India. Honor to have you with us, ma'am, and it's over to you.
Thank you, Rajlashmi, for your kind introduction. Good evening to all. So today we are focusing upon the psychosocial aspects in palliative care. So, we are going through a general, how generally we can do a psychosocial assessment. Okay. So I think you already aware about the definition of palliative care through our previous sessions, that the palliative care is an approach which improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems such as physical, psychosocial, and the spiritual. So here, the importance of psychosocial and the spiritual needs. We are not only focusing upon the life-threatening patients, but those who are having life-limiting conditions too. So they may not able to do their activities of daily living. They are having a lot of emotional threats, and they don't have to cope up with the daily social interactive tasks, and they can't able to engage with the community and the society as a normal person does. So here the importance of how, as a volunteer, we need to assess their psychosocial aspects. Okay. Before going into the session, I would like to specify why hospice care is something different from a hospital environment. So here we are focusing upon patient and family are the unit of care. So the patient and the family members are also involving in the decision making of each and every point of care which a palliative care team is providing. They are the decision makers, and they also need care along with the patient. Because in family, sometimes the caregiver who provide the primary care to the patient, and the family members here are also a kind of suffering they are also going through, and they become a kind of a silent patients in that family when a patient is suffering with any kind of threatness. So we are taking care of patient and family, both the psychosocial aspects is taking care well. Then care is provided in the inpatient facilities, and those who require care at home, we are reaching there and providing maximum comfort care in their home environment. So that also makes us different from other hospital environment. Next one, symptom management is focus of the treatment. Then palliative care treats the person as a whole. We know that in various hospital settings, due to their busy schedules, they weren't able to go in depth as the definition of health says. We are going to the physical, psychosocial, and the spiritual care. Everything we cannot able to met at one time of visited OPD settings and IP units in hospitals. So there we have to manage the patient and treat the patient. Here we are giving a supportive kind of treatment. So we are taking care of the person as a whole. We are going through their physical as well as their emotional factors. Next one, as usual, services is providing 24 hours a day, because we also have a pain clinic with our palliative care settings. So we are offering services in 24 hours. Then palliative care is interdisciplinary. Of course, in hospitals, we have interdisciplinary team members, but in palliative care, here, a multidisciplinary team will be calling every day to recognize what is need to be achieved as a goal oriented or and setting up a goal for the patient. So each professionals works on their own process and procedures, but focusing upon a general goal setting. For example, when a social worker is visiting a patient in an IP setting, they may find that a patient is so much depressive because he may not able to take food by his own. So, and the first priority of that patient is that he want to eat something with his own hand. So that is identifying by the social worker, but the care there is needed to provided by the physiatry team. That means a physiatrist, doctor as well as a physiotherapist need to work together for achieve that goal. So once that taking care well, that trust need to be making by the social workers. So this is something that we are all interrelated, and that kind of emotional feelings of the patient is also need to taken care by social workers by connecting them or facilitating them with the physiotherapy team. So the team members overall working together for achieving how he could able to eat by himself with any kind of assistive devices or by himself through a physiotherapy care. So like that, we can interrelate each and every goals with the team members. Then volunteers are an integral part. So here in Palim India, as well as in palliative care settings, we are working as a collaboration with the community participation, and the community is providing an integral part. That means the volunteers. So we cannot able to find out the homes where the patient is bedbound, and how whether the patient is able to take care by himself, or they can transport the patient if the patient is staying alone, or they can travel from their home to hospital. We may not able to get all these details. As I told, we are providing maximum care for the home bounded patients too. So their volunteers are doing a vital part. They are focusing their area wise, and they actually know about their neighborhood network, and how that area, and so we required volunteers in each of the community and neighborhood network. Then only we can provide maximum palliative care support to the needy people. This one, hospice care is community based. As I told, we require volunteers and participation of the community, not only the volunteers, but the support of government system, and a bioclustering of all the other professionals who can provide maximum kind of their professional support, and the care. Maybe the care could be essential for providing a kind of social integration to for that family to the society. So each one can use their talent and their professional background for a needy family. So we can identify that kind of a support. So that is one of the major part the social engagement team also looking for. And the other one is the bereavement services. So we may not end up our services after the death of the patient, or only by providing a death care certificate. But moreover, after 2 weeks of the demise of the patient, we used to call them, and we have to analyze whether how the grief mechanism, how they are coping with the demise of that patient. So that need to be also considered, because once after the death, the immediate days, there may be a lot of family members and relatives will be there in the family. So the real grief, and whether it is complicated one, or having any kind of more social or psychological issues is there, could be able to identify after 2 weeks to 3 months. if it is a complicated grief, or as we know that the death is a natural process. So after the death of the family member, each family member having definitely that grief, but we cannot able to identify how complicated it is. So once they are not able to coping with the situation, or back to their normal life, or not able to back to do their whatever back to their job, and these kind of, or any psychological pattern changes, these all things we can identify after 2 weeks to 3 months. So there we need a thorough assessment, and the team members, including volunteers, will visit the family and identify whether these family members here coping with the situation, or they are back to the society or not. So these are generally considered as elements in the hospice care. Um, so shall we move to the next slide? So why psychosocial care is important in palliative care? As we know, it's already been discussed, I think. Um, it the total pain comprises of the physical, psychological, social, and the spiritual elements. So as we see, these are overlapping, and each problem is compounded by these other elements too. So that's why psychosocial care need to be addressed for a complete assessment and a supportive management for the patient. So we can move into a scenario. Let's discuss this one. So here, a 44-year-old female, she is having type 1 diabetes. She's having severe pain due to ulcer of both lower limbs, and she's having blurred vision. She's having bleeding and a foul smell from the wounds, and she's anxious and scared. She lives with her 11-year-old son, her husband abandoned. She was a housemaid. That means now she is not able to do any job. She lives in a small hut made of wooden planks attached around, and no bathrooms and no proper flooring. She sleeps on a tarpaulin sheet laid down. So this is a scenario. Just imagine when you are going for a home visit, you could see this kind of a patient. We can leave the physical management, which is providing by the medical team, and moving into the psychosocial aspects as a neighbor of this family. How or what kind of support that you can able to provide for them? What are the important areas you will focus and identify your priority interventions? Just think the scenario. Imagine you are visiting such a family. So as a volunteer, what kind of support you will provided for this family? So this is open for your discussion.
So there are two questions. What are the important areas and also priority interventions?
Priority interventions.
Two questions. So for this patient, you can unmute from your end and speak or give your suggestions in chat. So we will start with the first, I guess, important areas to be accessed. Any answers to it?
You can point out, and let's have a discussion later on.
Health, finance, and counseling support. She is living alone, scared and anxious. Yes. Child's education, good.
Yeah.
Physical pain associated with the ulcer.
First priority is to relieve the pain.
Okay.
Yes, Manmeet. So leaving the physical part apart, start thinking on the other three dimensions and try to answer. Any more contributions? Alternate vocational skill for earning livelihood, yes. pain management and access, the financial aspects for bread only.
Okay. Husband abandoned, so we can think of addressing. Okay, moreover, what kind of facilitation or what kind of, you can be liaisoned with the many organizations and based upon your area. So you can maybe club them with the any resident associations or some NGOs. So think like that, and how you could help them without obviously economic support, that much we may not able to give, but how you can facilitate the neighborhood support system for this family. That is really you want to do with each and every families of palliative care patients. So you just think and let me know. Emotional support. She may get a feeling of burden on her son so that she don't.
So that she don't get into depression. We have one more comment before, make her more comfortable, like providing a bed.
Yeah. Refurbishing her house flooring, toilet. Yeah. Yeah, it is very important to do someone Aneka Bhav. Refurbishing her house, flooring and toilet. It is very necessary for this scenario because we know the patient, even when we looking into the physical aspects of this patient, even once we take up them to the hospital and doing some wound care, again, she is going back to the same environment. So what point we given that kind of wound care management without any wheelchair or any other supportive assistive devices. The flooring is like if it is also the food become worsening, no, if there is no proper floor means. Yeah, that is a good comment.
Reshma, I guess that is it. You can continue with it.
Okay. Anybody want to unmute and speak about this thing?
Yeah, ma'am. This is Srinivas here. So she lives in a small hut which is made up of wooden planks and no sanitary facilities, no proper floor. So we could address that, and her financial status also is not good. So some psychosocial support. So like somebody is there to help them. So that would give them a good care.
Yeah. Okay. Moreover, how we can provide that kind of support? We can say that we can provide psychosocial support. So maybe based upon the geographical area and the cultural background of our society, the support system which we can provide it in palliative care may vary. It is not same in all the districts of Kerala itself. So it could be changed. Anyway, this discussion will goes upon what kind of support Parliament is providing with the support of this community's engagement. Same like in your area, you only know that how the government system works or what kind of support maybe the counselors giving or any good NGOs or any other support system working for the upliftment of this kind of families. So based upon the support system which we are getting from the community only, we can engage or provide better care for each and every needy family. So that is the thing. So the psychosocial support system involves this kind of how we can provide a proper bathroom construction or how we can give a kind of, somebody told she need a bed for at least, and as said, she need a wheelchair So she's suffering with diabetes. So maybe she want to take insulin. So for storing the insulin, maybe she need a fridge, and she lives in a small hut made up of wooden planks. So there is no point of privacy maybe inside. She need a secure home, right? So a lot of these kind of things we need to think. Why I put this scenario means just for your thinking how we could able to connect them with the community or the society, because we may not able to give all the support system through our financial um, status, right? So that is the thing. And she is anxious and scared. Obviously, she needs some kind of interaction or communication regarding what palliative care or why you people come there. So all of things. So any more comments?
We received two more education support
Yeah,
for the.
ma'am. As the husband is abandoned, so we can enroll her a video pension from the government scheme so to get a
Yes, your voice
financial
is breaking.
support
We
in some
cannot
way or
able
the
to
other, which
hear.
will be helpful.
Mr. Srinivasan, your voice is badly breaking. Can you be there at a good network area? Meanwhile, Reshma, we had a very good comment. We can approach different NGOs, organization to help her for day-to-day expenses for food.
Yeah.
Ask the neighbors to visit her and bring food, look after her child and counsel her if she's scared and all.
Okay, yeah. That's a very good comment. So, like this, we have to think and provide supportive management. This is a supportive management. We cannot able to do everything by ourselves, right? So, think how we can facilitate, how we can listening, how we can manage, or how we can involve others in the society for providing care.
Ma'am, yeah, Srinivas, this side, I was telling that uh, the husband is abundant, so we can say that get that widow pension or something from the government to help her financially.
Yeah, good. And she may also get the disability pension too, right?
Yes, ma'am. Yeah.
Okay, that was a good comment. Thank you. Okay, so I think you got a general idea about how we need to address the supportive system. So I will explain you in detail the general things and factors, how we have to think about the psychosocial support system, and as a volunteer, what kind of care or what kind of supportive management that we can provide. Okay, moving into before moving into the theoretical part, I think Vaishnav, can we share the first video?
Yeah.
Okay, so managing your as a volunteer or as a professional, when we are providing a supportive care to those who are really having end of life care life, as well as having a threatening condition, it's very difficult because their management and their thought process, it's very difficult to identify or how what kind of supportive management we need to provide. That also we have to keep a thorough track for that. Because they don't want any kind of sympathetic approach, but moreover that we have to show them an empathy with a practical sense of what we can do for them for the rest of their life and management. So, moving into that, first thing, we need to assess the patient very well. This assessment involves the selection of goals and the interventions which we need to setting up based upon the assessment. And it is obviously a exploration process of gathering information about the persons. So all other physical aspects and the medical management will be definitely taken care by the medical team. So what we are going to get involved into their emotional as well as what are the threatening condition it's related to their illness. We need how we can interrelate or incorporate our support into their existing condition. So this assessment need an exploration process by gathering informations about the person. So how we could able to collect informations, or what are the relevant informations we need for that? Our major aim is to identify what are the problem areas which result from the illness and influence the well-being of the patient as well as the family members. So we cannot able to interfere into the problem or any kind of family conflicts which happened for many years, but as a result of this illness, how their quality of life can be improved by our interventions, that we need to be focused on. This assessment is an ongoing process as the psychosocial needs of patient and family and caregivers often changes over the course of illness. As we seen in this video, many of them having a different thought, and this thought process may change based upon their priority. Maybe sometimes first obviously they are having untolerated pain. Once the pain settle down, maybe the emotional issues comes in front. So based upon each visits, the assessment process may involves different kind of needs from the patients. The source of informations, we are basically collecting informations from the patient, first from the patient maybe, or from the primary caregiver. So thereafter, we are collecting information from other caregivers of the family and other family members. Then if we are not getting sufficient information for that family, then we are using other collateral sources like their friends, their relatives, their neighbors, local bodies, etc. Then what are the important areas to be assessed from the psychosocial point of view of total pain? Where generally we saw it involves the physical, psychosocial, and the spiritual one. But the psychosocial factors involves the patient overview, their insight about the condition, their family overview, socio-economic overview, psychological overview, spiritual overview, then setting up an intervention and plan. For it involved deeply many other matters, but that is only for the professionals. Professional palliative care team. So we required mainly the patient overview, insight about their condition, and family overview, socio-economic overview, and identify whether any psychological issues or any kind of spiritual issues is there. That's it. And if we find any kind of psychological and the spiritual issues, we can directly facilitate or consult them with a psychiatrist or a psychologist based upon the need of that family. So here, first one, the patient overview. When we are going to a family, first of all, I think the communication session is over for you. So when we how we can communicate with the patient by introducing ourselves and giving sufficient information. Then thereafter, what are the informations we require? Their basic demographic details involving their name, their age, then occupation before and after illness, and who is the primary caregiver and the relationship. Sometimes the primary caregiver is a paid one. So, but we can call them as a primary caregiver because they are giving or administering the medications at the proper timing, and they know what kind of emotional stress they are going on and how their social interaction would be. So it is very relevant to identify who is the primary caregiver of that patient. Why we are asking the occupation before and after illness to identify Once a general view about their financial status, or an idea about how the person would be, because maybe he was a busy man with a lot of businesses and suddenly stuck with any kind of diseases and completely into bed. It's having a big kind of emotional trauma for them. So definitely we need to look into what occupation they are doing before their illness, or it is stopped, and after the illness. And it's next one is the insight about the condition, insight about the diagnosis, prognosis, and palliative care. It's important that we are not we are not there for giving all the informations about their diagnosis, prognosis, and what all palliative care team is going to be doing there. But we have to identify what patient and family thinks about their diagnosis and prognosis and palliative care. That's it. We are not giving any kind of counseling or clarifying their doubt for the first time. These all points are relevant once the first visit of the patient and a general idea about how the psychosocial points can be related with the these kind of points. That means if the patient is thinks that the patient having liver cirrhosis, family members are hiding the exact diagnosis with the patient. Maybe patient having cancer of the liver. As a outsider, when we goes directly and how your chemotherapy treatment or how the cancer treatment is going, like that questions maybe suddenly get kind of emotional trauma for the patient. So we have to be very careful when we are talking with them, and it also avoid different repetitive communication with the family members too. So we have to identify their diagnosis, prognosis, and palliative care idea. And protest against the attitude that there is nothing more which can be done. So the thing is, there is a myth in the society that palliative care is only for the end of life patients, and most of the family members are not willing that a palliative care team to enter into the home, because what neighbors thinking or what the patient would think about that the palliative care team means nothing there could be done with the medical team. So that's it. It's going to be end their life. So these kind of myth and ideas is there in the society. So we have to give proper awareness for the family members too about how palliative care support can be provided, or what kind of support a palliative care team can be give to this patient and family. Next is the family overview. So we have to identify who all are the supportive system for the family. It's helpful for identifying the financial status, as well as identifying the bonding of that family. If there is a severe grief, or who is the strong bonder of that family, or who is holding the hand of the family members, who is that supportive man or woman in that family. Everything we need to understand for more communication, as well as providing more supportive care. So family dynamics, we have to ask about who all are there in the family, what they are doing, any kids in the family. So most of the time we may avoid to talk with the kids about the conditions and the prognosis. Suddenly something happened in the family. Suddenly they are seeing a death in the family. Many times we neglect the kids, what their thought process, what they are thinking. If it is in the case of their own parents, so that's an emotional trauma, or sometimes they may not understand what. And nowadays, many of the children are really, from the movies and the social media, they are aware about what is death and how the rituals are going on. So once it is seeing in their own family, they are thinking about, oh, this is what happened in my family. Nobody is talking to them about that. So once a patient is there in an end of life, Definitely, we have to think about the kids of that family too. What they are thinking about this condition, or what they are thinking about their parent. If something happened, how about the grief would be, and how can manage that. So these are all in our plans. So definitely, we have to go through that also. Then history of illnesses in the family. Any previous same kind of history, because. Any illness related death was happened, or multiple deaths maybe causes some severe grief. So these things also need to be addressed. So generally, what about the family? Who all are the family members? What they are doing? These all things we need to ask. Next one is a socio-economic overview, which involves basic details. As a volunteer and as a facilitator to provide kind of support system, maybe we are associated with some NGOs, or we are planning to take up some fundraising and giving this kind of support to the family. So we need to identify whether we are giving it to the right hand. Proper support is giving to proper hand. So thoroughly, this is one of the important area volunteers need to be checked out, whether the patient is having adequate food, clothing, and shelter. Who is the breadwinner of the family? Who control the finance? Sometimes those who are controlling the finance is staying abroad, and it is usually like the who is providing finance support to the family. They are in a good position to taking the decisions of that family, how the care have to change, what is the next step of treatment, which hospital they want to do that, or these kind of things may be planning, or decision makers would be staying in some other places. So we also have to get an idea about who is the breadwinner in that family. Then only if any kind of like those issues, or financial constraints, or any treatment changes, or taking this patient to any other advanced hospitals, or the transportation things, these all things sometimes we could able to communicate with them what clearly the scenario currently happening in that family. Maybe they are having some communication problem. They can't maybe express all the treatment strategies to the breadwinner. So there we can intervene and provide us a kind of support. And who is the breadwinner, what is their daily income, how they are managing their the treatment cost, as well as the other uh, expenses in that family. A source of income, whether it is from any external support, or those who are staying in the family, multiple breadwinners is there in the family, or whether they lost their control of this finance after they identify the patient as a I, maybe sometimes the patient itself is the breadwinner of that family. So it may be stopped there once he identified as a patient. So that also we need to identify. So we have to check what is the source of their income. And what about the debts? Maybe they are living in a two-storied building, but over the period of time with the disease, maybe the patient want some kind of dialysis or some expensive chemo medications. If they are getting 30,000 a month, but their expenditure is moreover maybe 60 or 1 lakh in a month, we have to check what is the income and what is the expenditure they are having. So and any possible anticipating debts will be comes in that family. These also we can check. Then what are the essential government schemes and local finance support that as a volunteer we can facilitate to that family, like cancer pension, and for the dialysis patients there is a lot of government schemes available. You can check it in the social security missions and the social justice departments websites. So there are a lot of schemes available for each disease conditions, so that can be we can update while looking into these kind of websites of government of India and Kerala, like whatever your states say social justice departments sites have to visit and identify what kind of support system we can facilitate with the government. uh, Next is the education of the children. There may be possibility of losing their education, maybe because of the illness condition of the family member. Sometimes there is nobody take care of that. Sometimes they are studying in some central school, or after this condition, the breadwinner fell down, so nobody is there taking care of them. So they are shifted from main central schools to a government school. Sudden change of this environment also cause trauma in the children. So what kind of education, or whether there is a chance for dropping their education or not, that is also we can ask to that family. Next is a psychological overview. This is just for your general understanding. I am saying, if you identify a patient with any of these situations, you have to refer them to the clinical experts for further consultations, like feeling overwhelmed, helplessness, or hopeless. That means they are not able to do anything. They are showing very irritation, and every time they are telling that I'm not worthless, so I'm very worthless, like that some situations. So we can identify how a normal grief, we all generally seeing what a normal grief is going, or maybe the death, or with the end of life, or with an illness in the family, right? But other than that, when we are seeing something complicated, like as I said, every time they are telling upon hopeless things, and feeling guilty at every time without a clear cause, worrying and showing anxiety, disturbed sleeping pattern, changes in the appetite, isolating from people or activities, or experiencing unusual anger or irritability to the family members or whoever communicating with them, and every time they are crying, or not able to talk with anyone. So that kind of abnormal responses, if you are seeing for any patients or family members, and if you have an idea, or have a doubt regarding something is abnormal I'm watching there in that family, definitely you have to uh, listening, or facilitating them to the clinical experts. Because once you neglect it in that family, or once you drop it there, maybe that comes as a disaster for the next day. Maybe the patient did committing suicide, or the family members did something, so that we need to avoid. So some if you find anything doubtful, definitely refer them to the clinical experts. So next is the spiritual assessment. I think you yesterday you had a good session about how the spiritual need of the patient is taking care. So generally, I can say that it is nothing but we are assessing an individual as an individual. It's not about connecting them with the God, but connecting them with their own life. So when we are doing, basically when we are doing end of the spiritual assessment for the end of life patients, there are some questions in depth it is having. Their connection with their own life, their family members, their childhood memory, their meaning, their most joyful moment in their life. So trust me, nothing these kind of questions would ask by anybody when they are in their end stage. I'm telling about um, those who are normal end of life process. If they are able to communicate, or if they are in the hospital setting, and those who are having some relief from pain and physical discomfort, and they are continuing their they in the hospitals. So over a period of time, they may be adjust with that hospital setting, and they are having some kind of loneliness. So definitely this kind of spiritual assessment will help us to change their mood. At least a person can just look into back and thinking about what I am and how I come from. Like that, something they can think about their life. So their connection with everyone, their family members, who is their strength and who gives more comfort in their entire life. Uh, and they may also tell about their childhood memories, which is their most lovable memory, or what is the happiest thing in their life, and their hope and concerns. Indirectly, sometimes for the end of life care patients, with asking their hope and concerns, we could say that is the last wishes or the death wishes, like that. What are the things which till now you think that is unfinished one? What you want to do for the next days, or would you like to do something like that? So these kind of questions will help us to identify what are the things which unfinished task which they want to do in their life, or unfinished task their family members want to die. So this will help the family members also to avoid some kind of guilty feeling about, because they are getting an idea about what the expectations of their about their children for the patient. So it is very helpful when we are asking about, simply generally we could ask about their connection, their life meaning, what you think about your life, their what are the joyous moment in their life, what are their strength, who are giving that much comfort, and their hope and concerns. So delicate thing. So normally the professionals will ask after at least a 2 weeks rapport with the patients. So this is something which was done in the IP settings, that a patient was said that his wedding day was in upcoming month, but this patient was on end of life care. So after the spiritual assessment, patient said this is something which I think I would not able to do after 2 months. So this was revealed with the social worker during psychosocial assessment, and you can see the smile of this patient, that as he was approaching to the death, but he, even it is not in the same day also, he was celebrated his wedding anniversary with his wife. So something like this, we can have some, we can arrange or have some joyful moments for our patients. Then some possible social impacts of the disease condition may: social isolation, increasing the dependency, financial instability, lack of social support, debts in the family, loss of work, interpersonal issues, and inadequate facilities. So here, when we look into, as a volunteer, when we look into the family, we have to think what kind of support system they are having, whether the family is connecting with any healthcare services. You are visiting a family and thinking about how the neighborhood network would be, whether there is any adequate health services there, primary health centers or community health centers, government health center supports, any extended family is living around, any friend circle, neighborhood network, and what about the workplace? Is it near or far? Local services, any clubs or residents associations you can connect, and any religious institution support to that family. How any school, maybe if there is a kids, how far the school is, So these things generally you can identify to extend your support. How, from which area we need to work out to provide a support with the family. If you are finding out that the family does not have any friends, and a neighborhood network, definitely as a volunteer, what is our aim? We have to check out how a community linkage can be provided to this family. So there our thinking process need to do. And what kind of local services which we can provide. If nothing is there, at least local self-government authority members is there, no? The councillors or the ward members or the panchayat authority, somebody who is responsible in the local self-government, at least we have to connect this family with them. And we as a volunteer, you can say that I am a palliative care volunteer. See, there is a family, this family need this kind of support, and there is nobody is taking care of. I am just addressing this family's issues with you. You just take care of whatever things you can do. Definitely, I will contact with you for further, follow up with that family. They can't neglect that, because they are the local self-government members, have to take care of, or being a responsible member of that particular ward or society. You should address them with them. Okay, that is a thing which we can done. Then so from here, I am telling you about how the volunteers can involve into different area of palliative care works based upon your profession and based upon your interest. Because we comes into the social services, and we are from different backgrounds, so you can having different capacities for providing. If there is a vocational training is providing, if you are from a management area, or you are well in a business, you know how to help them with by providing any kind of business support. So how they can get survive with that. So that kind of guidance supporting system that we can provide. So like that, many areas with the many professional support needed for each and every patient's family. So as I said earlier, it depends upon the area where we are living. It's not same in everywhere. So based upon the community and the neighborhood network, the support system which we are providing will also change. And the NGOs or institutions which we are associating also, their vision and what kind of support system the NGOs are providing. So we can associate in that way only. And the other thing which you can do, you can search it out, what kind of other support system providing by other NGOs or organizations, and facilitating them with the corresponding institutions. So you can be the part of the vocational training. As you can see, these are the volunteers. They are helping them to make a paper bag. So this family is into a paper bag business, and he's a wheelchair bound patient. This is his wife. So they are helping, or they are making, they are giving training for how to make paper bags. And next picture, you can see a petty shop which is provided with the family. So here what volunteers are doing, they are visiting that family and addressing how the neighborhood network, whether any other shops are there. If yes, what are the materials which we can provide in that particular area. And they are also helping them to identify and purchasing the materials for the shop, and provide a necessary guidance for the marketing also. So these are the things which we can do. And also for the wheelchair bounded patients and those who are confined in four walls, you can make them to encourage, or them to make some kind of recreational activities, because when we are in a alone in home, most of them having a lot of loneliness issues. We are spending, if we are taking our time and spending some time with them, maybe for a talk or engaging them with this kind of activities, which would be really helpful, that volunteers can train them and giving such kind of recreational activities. This is also kind of facilitation of the goat farming and poultry farming for a family. What I said, like identifying the socioeconomic condition of the patient. If we found that they are not able to survive with their existing expenses for an additional income, or to avoid loneliness, or make a sufficient income, we can definitely help them with these kind of vocational support, or helping them in your own area for finding the patient and providing medications, and helping them by distributing the assistive devices as well as the food kits, and the supportive care. So this is also one kind of engagement of the volunteers. And this is a mentoring educational support. So this educational support is running by the volunteers of Palim India. So they are taking care of the students from 8th to 12th standard, because that time they need a career orientation as well as a proper mentoring. So from different, you know, we have different kind of professional background, and those who are from the those who are more interested to engage with the students, and from if the professors and teachers, they can also having conducting this kind of career guidance and summer camps for these patients, children and family members. So these are the children of patients, those who are with the Palim India, and we are having education support program, so that we are giving a financial assistance once in a year, as well as continuous mentoring support is providing by the volunteers. So these volunteers are taking care of 4 or 5 children, and they are taking them into counseling services. They are providing mentoring them with the for their education. They are having a connection with the school teachers of their school, and they are assessing the progression of their studies. So this is something which really you can done. And make barrier-free environment for the patients. So we know that the wheelchair-bounded patients are in their own home. So how barrier-free environment can be provided to them? This is something we can do. Either maybe we can enlarge the width of the doors of their home, or making some ramp construction, and taking them outing. So these things are really an entertaining one for the patient, their family members, as well as for the volunteers also. Really, this is a like this, when we are spending our time for their happiness, is really a great thing which we can see. Bereavement support program. This is also another thing we can engage, that after the death of the patient, so the family members, as I told, how they are coping with the situation. If you are finding difficulty, or when we are connecting them with the bereaved support program, which is running by the volunteers here in Palam India. So this kind of group can be organized by the volunteers, and we can call the the family members, and take part, tell them to take part in this kind of meeting, where the common goal for this meeting is to relieving that grief by hearing others how they are coping with their situation, and others in motivational stories would definitely help them to coping with the situation. We cannot able to compare one's grief with the another one, but obviously the motivational factors which definitely they would get from others story, so that give a strong bond between these volunteers as well as with the other bereaved persons. So this is something, another one that a volunteer group can be run, bereavement support programs. And how this things can be happen. So in Pallium, fundraising programs, these are the fundraising programs organizing and running by the volunteers of Pallium India. The second picture is a painting exhibition that was collected by the painting was collected from famous painters and actors. The first picture is a a food festival. So we are approaching MNC, multinational companies, and some commercial complexes, and telling about how our patients are. So many of the patients' products, as well as volunteers itself, is preparing something special for the day, and we are selling that food products and arranging it in a particular day. So like that, a collective fundraising can be done that can be used for the educational support of the students and purchasing the assistive devices for the patients. Just for your idea, I'm showing all this. So basically, what are our general interventions involves? Family meetings, psychological support, facilitating psychoeducational support groups, recommendation for government schemes and other financial assistance, linking with the community resources, vocational training and rehabilitation, and regular follow-up. This is ABCD of Dignity Conserving Care by Dr. Harvey Max, that we are from different backgrounds. We may have good positions in, maybe we are a CEO or we are a boss of, a company, whatever itself. But when we comes into a palliative care team, when we are approaching the needy people, we have to approach them with our attitude, behavior, our compassion, our dialogue, that this ABCD into a very cute, empathetic approach we have to show there. And we don't have to explain what are the experiences, and as an educator person, these I was like this, and we have this kind of experience, nothing like. But we are there for listening the patient, we are there for providing practical care, and how our approach will help that family's quality will be improving. So that is our aim. So this is something which we need to think in our mind when we are a family. They really need our help, and we are approaching the needy people. How our support will change their life, that we need to address. Okay, I think Vaishnav, shall we show the support video? So we can see the rehabilitative support for the women caregivers. That is also one of the experience patient in this. So here all we can help by providing our time to avoid their loneliness, improving their social interaction, and facilitating support to these families. So this is about the psychosocial care which we need to focus when we are volunteering with the palliative care service. And if you have any queries, or we need to discuss anything about more, so we have a discussion with that.
Thank you, Reshma, for that very informative session. It gives a full idea about how as a volunteer you can support our patients and all. So we got a personal message. Do you think group therapy, multiple people who have gone through passing away of loved ones, or one-one therapy is more effective for families for recently?
Some, Raju, I couldn't hear the last portion.
One second, I can repeat. Do you think group therapy, that is multiple people who have gone through passing away of loved ones, is more effective than one-to-one therapy for families who have recently deceased person?
I think this approach need, I think it's required for both, because once we have an one-to-one session with the family, we can identify what are the concerns they really having. So based upon that, we can relate them with the a group therapy one. So we can identify what kind of grief or what are their major concerns. They want something, make it into private. So they, based upon their interest also, only we have to engage them with the group. So both are effective. In a professional way, I think one-to-one therapy we can do in a professional way, I guess. But moreover, for a general, a motivational thing, or improving the social interaction, a group therapy would be more effective. So they get a general idea, or they are having an experience sharing with the other members. Moreover, one of our major aim is to reintegrate them into the society. They may be there in that home for many after the death. There have some rituals, so there, and they maybe lose that track of social reintegration. So this is one thing which we can do through the group therapy. So either way, both are effective. But the one-to-one section really required a professional hand also. But as a volunteers, group therapy would be more, we can done more with the group therapy.
Thank you, Reshma. I hope it was answered well. So we are moving to the next question. How can we intervene in cases where patient and families are being shunned by neighbors because of illness like cancer?
Assess clearly what kind of issues or happened there. Maybe there the lack of neighborhood network is because based upon the family's personality or their relationship with the neighborhood network that happens from past time itself, or if they are identifying that with the cancer, any stigma is there for the neighbors. So we have to definitely identify what kind of exact problem is. If it is about a stigma, definitely we have to communicate with the neighborhood network, and we have to clarify all the current doubts relating with that. And then also, if the problem persists, definitely we have to identify a team there, maybe other neighbors or any other persons which we can approach them. Maybe there may be some medical professionals are there, or they can be talk with this the neighborhood family moreover than us. So maybe they are having a good relationship, so like that we can identify. Or else if this family is not suited with them, we can identify another family for a kind of supportive therapy. And if it is because of the stigma, definitely we need to intervene in that. We have to provide awareness for that.
Thank you, Reshma. I hope, Manaka, it was clear. Any supportive questions?
Madam, one question. In the assessment slide, you have said that we have to go do a comprehensive assessment and form the goals. So the goals are set by whom? The assessor or the patient itself?
Assessor, with the involvement of the family. So
Ah.
anyway, we have
So
a palliative care team there, no? all the involving all the professionals such as doctors, nurses, volunteers, and social workers. So we have an initial discussion. Then, based upon our findings, we have to talk with the family members. Then we need to set up the goals.
In that goals, ma'am, the team may feel that this goal is suppose according to the team, they might be interested in fixing that goal as number one, but the patient is interested in the some other thing. So it would be patient-centric goal, no?
Yeah, patient-centered goal need to do first, but we have to consult the medical team members also. If that's, you know, ideally, if there is something which need to be prioritized by the medical team, that have to be do firstly, right? So based upon that, we have to talk with the patient and family members. Anyway, that is patient centric, obviously, but you know, the multidisciplinary team also have to get a kind of concerns related to that. You want to say any specific examples, Srinivas?
Like the patient is having a bed sore and all that, and but he's very much concerned about his family and all that. So first, we will be considering about his physical thing or about his family. Which one will be first in the goals actually?
Okay, if it is related to the physical and the emotional concerns, we can move in both way. Okay, the management by the physical management will be going there. At the same time, we can addressing the emotional concerns of the patient. But if the patient want to, examples like the patient want to sit and wanted to doing his job with his existing pressure zone, so that concerns may not be encouraged by the medical team. Right. So like that things we have to check with the team members and finding the alternatives, what else we can do. But obviously the emotional concerns, anyway, the social workers are there, clinical psychologists are there. So we are working together. No. So the physical aspects will be taken care by the medical team. At the same time, medical team itself having identifying any kind of these emotional concerns on a collateral basis, social workers and the clinical team members are doing for achieving that emotional concerns solved. Okay.
Yeah, ma'am, that is fine, ma'am. But ma'am, when we talk about palliative care as a multidisciplinary approach, where it requires a team in place to take care of all the dimensions and the multi-dimensional sufferings what the patient is going through. So, but when we see the rural India,
Okay.
majoritarily they don't have any kind of a qualified medical practitioner. They all depend upon that quacks. And where can we expect? Is it really possible in the urban setup? Okay, we can expect that. But in the rural areas where the care is more, where our palliative care is required in a larger quantity, because they come for the treatment into the rural, from the rural areas to the urban hospitals, get them stabilized there. Again, they go back with a stroke, they go with the disability, and they lifelong they do like that. So have Pallium India has been thinking of it? Has it developed any protocol in order to develop the manpower?
Srinivas, can you continue? Develop manpower? Anything more to add to it?
No. Develop manpower and address this issue, ma'am, actually in rural areas. Because these kind of like healthcare providers like psychosocial, psychiatric social worker and clinical psychologist or a psychiatrist, I think they are not at all available in the urban areas too. Then what kind of a situation we can expect in the rural areas?
So Srinivas, while telling about the Parliamentia's one's goal, we also have a state facilitation team working in many different rural areas of many parts of the in India, and they are finding out the professionals as well as those who really helpful for integrating social services and palliative care into their rural area. We are picking up that kind of organizations, hospitals, and professionals. That's why I think Raju also can contribute.
Reshma, can I add on to what you're saying?
Yeah, you are here. Sunanda.
Yeah, I'm here.
You are definitely, she can give a more extensive answer for this.
Yeah. So, okay. Good evening to all. So, as Reshma was saying about the state facilitation team, so I'll just quickly tell you. Actually, tomorrow I was supposed to say now, but then the question has come up. So, I'll just quickly say. Paraminda is now scaling up to across the country. So, we have regional coordinators all across. So, like for me, I'm looking after the central India. Like I'll tell my states: Maharashtra, MP, Chhattisgarh, Goa, Gujarat, and Orissa. So coming to my states, what we are doing on behalf of state facilitation, we are meeting the health department. The first thing is we're meeting the NHMs. We're trying to tell them how, Paraminda is working, and it cannot be exactly the copying of what is happening in Paraminda, but there's a state policies on palliative care which we're trying to implement. So we meet the state health department, we meet the state drugs controller, and as Reshma was saying, we also meet the organizations and NGOs who are working or willing to work in palliative care sector, and also we have volunteer based. So this is a beginning. So like suppose in this training we have a lot of volunteers who will be later on interested to work with us. So we'll create a volunteer database, whether it's from MP or Maharashtra or anywhere who's interested. So it's a baby step, and definitely I think we are looking into, as Mr. Srinivas was saying his concern. I completely agree. There's right now you cannot say that rural India is equipped enough, but we are trying to do it in all ways possible, like training the doctors, nurses, the social workers. We have variety of trainings, virtual and in-house also. So we're trying to first equip them with a lot of information trainings and all that, and then we have we'll see how we can break through and meet the needs of the rural people. I think I'll end with that. Thank you very much.
Thank you, Sunanda and Reshma. Any further questions, Srinivas? Or was it answered?
Yeah, ma'am, that sounds good. Hope so. This will be soon. All our volunteers with a great bundle will try to help the needy people who have been suffering and they require palliative care. Thank you. Thank you, team.
Yeah, thank you. And Srinivas, don't worry, tomorrow we have a session. We'll talk a little bit more about it. Tomorrow will be the last session. We'll talk more about it. Thank you.
Thank you.
Okay. Any more questions? Otherwise, Raju, we can wind up the session.
Any pressing questions? No, I guess.